Okay. Wow. Well, I just introduced Dr. Marsha Guest while I was waiting for you to call me back, um, but I don't have a bio um, for the second physician. So tell us about yourself. Were you a part of this study that Dr. Marsha Guest was a part of that she conducted about?
Yes. My name is.
Oh.
Can you hear us?
Your name is.
My name is Dr. Kathleen Connell, and Dr. Guest and I have been colleagues that have been working together for years. We both are urogynecologists, and we did our subspecialty training together. And actually, part of our research thesis was looking at women with sexual dysfunction and how genital sensation plays a role. We see a lot of women with pelvic floor disorders, which includes urinary incontinence and pelvic organ prolapse, which affects sexual function. And one of the initial studies that we did looked at women with sexual function, and we found that women with sexual dysfunction actually have underlying nerve disorders where the nerve sensation is altered compared to women who don't have sexual dysfunction. And then Dr. Guest continued on some of those studies with this study, looking to see if stimulating the nerves can actually treat the sexual dysfunction. Before we diagnosed that people had some nerve sensation changes, but we wanted to see if we stimulated the nerves, could we help with these problems.
Right, yeah. So I'm not sure if the first study or the second study, but how many women are affected by sexual dysfunction?
Overall, if you look at the research, there's a number of epidemiological studies that have been conducted sort of nationally and internationally. And on average, most people say about 40 to 50% of women suffer from some form of sexual dysfunction. And there's sort of some subcategories of sexual dysfunction. They include arousal disorders, orgasmic disorders, which is what we study specifically, but also just hypoactive desire. And some women suffer from having pain when they experience intercourse.
Yeah. So what prompted the two of you to be interested in female sexual dysfunction? And because, if we think about just sort of historically the whole notion of women, the female body, and the female body being an object of desire as well as possession. And on the one hand, and the other is the female body, depending on, what skin you were in, is to be, is to have children and then you go be quiet somewhere. So the whole idea of being even interested in whether or not women are healthy, have healthy sexual function. It just, I don't know, sort of the idea that would even be a topic for research. And you all are female doctors. It just sort of, I'm just wondering about just the whole idea of the research, of the timing of the research, and sort of, are you a part of a legacy of such doctors that have been looking at this, or are you new? Like, are you bringing to awareness something that should have been addressed a while back but wasn't because maybe there was no interest in it?
So I think it's sort of a combination of things. Importantly, our subspecialty training is in urogynecology, which is a subspecialty that deals with women who have conditions, urinary incontinence, meaning they leak in their underwear or in pads. Pelvic organ prolapse is when your female organs actually start falling out of the vagina. And
that's typically related to childbirth, and I think you're right that women do get ignored sort of later in life.
When these things happen, the focus comes when you're delivering that wonderful, beautiful child and expanding the family. But then after all that stuff has happened and you're still suffering with some of these disorders, you sort of get, undervalued, lacking attention.
And nobody talks about it. It's called the silent epidemic because if you don't tell your doctors, a lot of times people don't ask, and a lot of people suffering out there unnecessarily.
And so with that, we started seeing a lot of these women who, when you start asking questions about incontinence and prolapse, the next thing that just sort of spills out of their mouth is also, and because of these disorders often, or in addition to these disorders, I'm having problems with sexual function. And so when you see enough women, you start to realize, without looking at the literature, how common these problems really are. And I think for me, it was very interesting to see sort of who was telling me these things. I think a lot of times people think it's a marginalized population who's telling you. But in fact, we would get people who had been married for 10 years who had never had appropriate or enjoyable sexual function with their partner. People who had been married for 20 years and started having pain with intercourse as they started entering menopause. And so to sort of fully treat our patients, we realized we couldn't just isolate ourselves to urinary incontinence, pelvic organ prolapse, because we have to treat the whole woman. And in seeing that and seeing this being such a prevalent condition, we started exploring this a little bit more. And that's really what prompted that initial study where we took our patient population and looked and found that in these women who had these complaints, they had some sensation deficits in their pelvic floor. And sort of rather than looking at sexual function as just a complaint from women, we were really sort of charged with trying to figure out what could be going on anatomically, what could be going on with their system where this complaint just kept reigning true. And as we said before, with those deliveries and that nerve stretching, that was one of the first things that came to our mind. Could that also be contributing to the sexual dysfunction? And in our earlier studies, we found that it was. And so we decided to keep moving forward with those studies and try to figure out, well, if that is a potential cause, how can we sort of identify a potential solution?
Right. Yeah. And the whole idea of, I was just thinking when you mentioned the sensation deficits, that maybe, women have come to feel that not having enjoyment, from sex was normal, that they didn't know that anything else was possible. And I guess maybe the pain might have been the presenting symptom that made some women get help. And then through the treatment, were able to learn about ways that they could actually come to enjoy sex as opposed to feeling it maybe that is their duty if they're married so they can have kids. And then after their childbearing years are over, then they could, sort of hang up the hat and be finished with all that. So I was wondering if you could talk about sort of the curative part of the, your treatment around the arousal and orgasm that disorders and ways that you all sort of help women heal from that, and the importance, like why is sexual health, genital health, not just the physical, but the other, enjoyment part of it, why is that necessary for our overall health of our body? And also, sort of the mental, the body, mind, spirit aspect of that, too, if you want to talk about that.
Well, I think in our field, we are in some ways dealing with so many women. We have been fortunate enough to meet a number of women who have really good relationships and positive intimacies with their partners. And as I mentioned before, I think the face of the person who would come to us and tell us they weren't experiencing orgasm or arousal was not what many people thought. It was people who had been in very stable and lasting and secure relationships, yet they did not have that aspect being fulfilled. And so for us...
And they have a lot of guilt, I think, that goes along with it. They say, my husband feels bad, and then they feel bad, and it seems like that really starts to affect the relationship, even in a good relationship. And I think that does affect their mental health and how they feel.
And so with that, we felt like, well, this seems to be affecting the whole unit. It's not that she's good and he's bad, or he's bad and she's good. We found that a lot of them, both of them, were having, as we mentioned, guilt and disappointment. And it wasn't, he felt guilty that she wasn't getting the same experience as she was. And she felt guilty because she felt like because she wasn't getting it, she wasn't making him happy. And so realizing this, and it's very similar in those conditions that we deal with, the urinary incontinence and the prolapse. it's trying to figure out where all this fits into being normal, and do we have a normal relationship if we're experiencing this? Well, pelvic floor disorders, 1 in 4 women experience them. And so although people don't want to talk about it, these are prevalent conditions. And so we found that because they are so common, we have to tackle them as a group of conditions that tend to coexist. And the only way to bring someone the quality of life they're looking for in their treatment, you have to tackle this as a whole unit and not just focus on one thing and ignore the other things that are going on with the patient.
So what are some of the ways that you treat it?
Well, we definitely work with sexual psychologists who are really good, like who do counseling, marriage counseling. That's actually been shown to be effective in studies, saying that it definitely helps with the relationships. As urogynecologists, we also address the physical too, in the sense that many women, when you have these neurologic deficits, sometimes it shows up in sensation, but often the pelvic floor muscles are weak, and people have trouble, holding not only their urine or gas, but also using those muscles during intercourse. So when we send people for physical therapy, a lot of times that helps too, because then they're strengthening the pelvic floor muscles. They feel more empowered. They actually have control over this part of the body that they've actually lost control of for a while. So I think that's also reinforcing for them, and something that they can do that's not surgical or medications. And we also see women who are often menopausal or perimenopausal, near the time of menopause, who have vaginal dryness, so we can treat them with estrogen, topical estrogen in the vagina, or lubricants. And really, a lot of times people even find group therapies work, and when they can talk with other people with these issues, that's also helpful. So as Dr. Guest mentioned, it's sort of treating everything as a whole. I think if you just focus on one, just the psychological or just the physical, you'll get some improvements, obviously, and those are helpful, but it's really working together with subspecialists and in other fields.
And I think that also brings us to the current study. Those were the things that we traditionally treated people with, and they worked. But if you start to look in the literature, there were sort of rumored things about sort of vibratory devices, vibrators, and saying that they may work, but there was no real study to truly show that these devices were beneficial to women. It was usually cross-sectional studies where someone said, oh, yeah, they work for me, blogs, comments in the newspapers, but it hadn't really been systematically studied over time to see what would happen if people use these devices. And that's really what prompted us to move forward with this. So we worked with the device manufacturers. We looked at a lot of the literature on this particular device. The concept of this device was that it works without numbing, and the motor itself can continue to oscillate even if you increase pressure. And so when we were talking about nerve function and seeing that the nerve function, the nerves were dysfunctional, the thought was, well, if you have decreased sensation, what happens if you overstimulate a nerve that is lacking in its ability to function normally? And could that potentially offer you some sort of therapeutic benefit for your sexual dysfunction? And that's really how this study came about. And it was basically a prospective study, and that means we just follow women over time. We didn't know the answer to our question, so we basically brought them in, we introduced them to the device, and we asked them to use them. And when they used this device, they actually found that their sexual function improved, and this was not something that they just walked in our door and said, oh, I'm getting better. We actually gave them validated questionnaires, and those questionnaires asked them specific questions about their sexual function and about the frequency of intercourse and their satisfaction with it. And when we went back and looked at all the data after collecting it on these women, over 65 women, then we found that, in fact, sexual satisfaction, sexual function, the frequency of orgasm, all improved in these women over time. And we were pleasantly surprised because, as I mentioned, we don't really have a lot of other treatments for these women. And so this was particularly important to us because the women who have arousal and orgasmic dysfunction, it would make sense that this is the group that may have some kind of functional problem with their nerve that's preventing them from having these experiences. And so, again, it was very, very exciting to us to find that there may be a treatment for at least a number of women who are suffering with these conditions.
And you recommend a particular device, right?
Well, that's the device that we used. There haven't been any studies that look at, let's say, a vibrator, which goes back and forth in one direction, versus the arousalator, which goes more in a circular motion. But certainly, I think those studies are warranted. The goal is to really have things easily provided to women everywhere, that they can use something at home. That's the best part, is something that they can do at home in their privacy, that's cost effective in the long run if it's something that you always use. So these are things that we have to look at down the line to see. This is a very short-term study, but we were really surprised and pleased that women were responding in such a short, only a few weeks. They were noticing improvements in their sexual function, and actually their sensation by our testing actually improved as well. So we thought that was really exciting.
Right, and you mentioned sort of recommending a device. I think the concept is simply, if you go to the corner store and you buy something and it doesn't work, you can't say that our study isn't valid. I think we purposely, systematically, not only looked at the patient's response to this specific device, but we looked at their nerve function, and we found with this particular device that nerve function, the sensation that they have in the pelvic area, improved over time with using this device. So to replicate the results, I think we would need to use the device that we use. I don't discourage someone if they have a device at home that's working for them. I don't say throw that in the trash and go look for our device. But I think if you don't have one and you want to improve and use our study as a guide for that improvement, the only device that we can speak about is the one that we study.
Right. Yeah. I looked up the device, and I was just it's an investment, and I was just wondering, for the study, did the women who were part of the study get the arousalator as a part of the study, or did they have to purchase it?
So we did actually.
And I was wondering also. Oh, sorry. And I was also wondering, is it covered through like a person's insurance? That might be another way to be able to purchase it.
So I'll start with the second question first, because I think that's really an important one. I think one of the reasons we did this study is that the current sort of belief and dictum is that these are sex toys, right? When you talk about vibrators or vibratory devices, you go to the sex shop to buy these. And as I mentioned, the type of persons who were participating in our study were not prepared or did not desire to actually go to a store to treat their problem. And so by changing this and making people recognize this as a medical condition, I think it allows us to now move forward and see if perhaps in the future we can get these things covered. If you can actually show that there is some kind of physical component to sexual dysfunction that can be treated effectively, then I think you can get support to get these things covered by an insurance company, which is really one of our ultimate goals. When you look at things like Viagra, you have commercials, you have prescriptions. Currently, women now have to walk into a sex store to get something that really could treat their problem. And so I think for us, doing studies like this is very, very important, because you can take it from being a sort of a condition that carries negative stigmas to just a traditional classic medical condition, which is what these women are dealing with.
Right.
Right. Yeah, that would be super. And I was wondering, I was looking just sort of like next steps with regards to your research. What are you looking at presently besides this study actually is a great way, as you mentioned, to for people to be able to get the kind of help they would need, through their insurance, their medical coverage. But I was wondering also sort of what are you looking at with regards to other areas that might be under not as well known that are affecting women, particularly around vaginal distress. And I was just wondering sort of what you're looking at presently.
Sure. So the next step, to answer the first part of the question, so we did what's considered a small trial. What was nice is it was prospective, meaning that we followed people. We had our set parameters to show that, we could eliminate, things that could bias the results. But in order to get this as a true treatment and approved, you need to do large, like NIH-funded trials. So the next step would be to do a much larger trial looking at this device or maybe even others and doing it at like multi-center on hundreds of women. And then if you can show that again and reproduce your results, then it goes through the FDA process of like a device approval. It's not until you can show that things are effective in these large trials. They have like phase 1, phase 2, there's specific process to approvals by the FDA in order to get things then covered by insurance. And in terms of things for next steps, what we always see, what I always call the trifecta, it's aging, menopause, and childbirth really impact women's sexual function, their pelvic floor muscles, and their pelvic organs like the bladder, the rectum, and the uterus in terms of their position and our anatomy. So really what we are focused on in our group is looking at how vaginal delivery, how we can intervene in the postpartum period right after delivery to see if we can prevent these, if people are having problems, maybe stimulating them early might generate the nerves better and prevent some of the muscle weakness that we see 20 years down the line, so that they don't have to see a urogynecologist when they're, 60, 50. And also just looking at treatments for incontinence and prolapse and really working with colorectal team, gastroenterologists, physical therapists to treat women as a whole.
Yeah, because when I think about some of the things that you mentioned, I particularly around trying to think what's the word incontinence. I sort of think about those cultures where girls are married off when they're too young and their bodies have not developed so that they can actually have sexual intercourse, not to mention have babies. And you've probably seen all the movies and probably know some of the doctors that are doing all the studies. And I'm thinking, wow. And you never hear about it in the West, that it also happens to people here, like women here in the West, for other reasons. So I just think it's really interesting, that we think it's over there, but it's not over there. It's here too.
Yeah, absolutely.
And not just here, but here and prevalent. As we mentioned before, 1 in 4 women.
Yeah. Oh, you're right. Yeah.
Form of pelvic floor disorder, and that includes urinary incontinence, pelvic organ prolapse, or even fecal incontinence. And so 1 in 4 is quite a significant number. It's not something to be ignored. So I agree with you, and we really appreciate you inviting us out, because this is how you get the word out. This is how people understand that there are lots of people suffering. This is how people understand it's not just those people, but it's us as well, and that married women in stable relationships are dealing with these same disorders. And so they need something to help them improve. And the more we do research on devices like the one we did it on, and get closer and closer to identifying more and more treatments for these women, the better off I think our society will be as a whole.
Right, yeah. So, Warning, in closing, would love to have you on again, and I hope you get to do the larger study. Um, what is sort of, I mean, you mentioned some of the indicators, but I was wondering, does a woman first approach her gynecologist? I mean, how can you just sort of just do a checkup and make sure that everything is the way it should be? I mean, I'm thinking that when women go to get their checkups, you know, pap smears and things like that, that I would think that these other areas are also checked, but maybe not. So, is there, like, when you get a checkup, can you ask for those kind of? How do you maintain
yes.
a healthy?
It's
true.
I mean, we really do need to be our own advocates because, like I mentioned before, it's the silent epidemic, and a lot of times we're telling doctors now, if you don't ask, patients won't tell, and a lot of times doctors weren't asking. So there is a big push to get the education and awareness out that there are treatments. It's not a normal part of aging, and that help is out there. You can see your gynecologist or your primary care, anyone who's doing your pelvic exams. Even if you've had a hysterectomy, you should be getting pelvic exams to have the ovaries checked. And a lot of times, sometimes though, a lot of generalists will just say, oh, I don't know, they're not as comfortable with these things because they're not as familiar. But it's always important to ask and to say, hey, is everything looking okay? Are things in the right position? Certainly if you see or feel a bulge, if you're leaking urine, if you're having trouble holding it, those are things that are great to see a urogynecologist for. We do have a website that we've really worked hard on just for educational purposes. We do blogs and we talk about foods you can eat or things to avoid. So if you look at Colorado Women's Health, it's Urogyn, UROGYN, Colorado Women's Health.com. That has just information. If you go to the patient education, we try to update it. We have a newsletter. We send things out. So if there's things that are new in the urogynecology world that may help patients. I know you guys are not in Colorado here, and that's okay. We just want people to know that things are out there. There are great urogynecologists all over the country. But that's important to know. So it's Urogyn, ColoradoWomen'sHealth.com.
And also for those women who are interested in the device that we studied, it is called the Arousalator. It is available online. You mentioned access. It is available online. So even though if people can't find it in a store near them, they can go online and identify it and find it via mail order. We have found that a lot of people don't want to go into a store, right? There's still that sort of stigma associated. We're trying to get rid of the stigmas. We'd love to have them in grocery stores and in all the local pharmacies. Currently, you don't see those in those stores, so they can go online and find that particular device. Again, it's the Arousalator is the name of it, if people are interested. We are not affiliated with the organization who did it. We actually are physicians at
who use their device,
who just use their device to study because we needed a device that had a rationale behind why we would use it, and it seemed like their motor offered a good way to stimulate without providing numbness. So that is why we use that device. But I do think it's important to know that we do not have any affiliation with the company themselves.
Right. And I have to say, as an academic physician, we were pleased with that company because they did take a risk. It could have come out negative for them that maybe we didn't find sexual improvement or maybe people were going to have negative effects. So I have to give props to that company because that probably was a bold move, but I think they do want to show that they are really strong believers in their product because they've been in Europe, and I think they've had great success, and people really seem to love it. So I have to say, we, like Dr. Guest mentioned, we don't make any money off of any of these sales. We're just academic physicians, university-based. We don't have any conflicts of interest, meaning we don't make money from any companies. We actually don't give talks for companies. We actually have NIH-funded grants, like through the government. So just so people know. But we do think it's a great product based on what our patients were telling us and the success that we saw. So we just wanted to throw that out there. We're not an advertisement for that brand, but they were very nice to donate those and take the chance to say, hey, well, let's see what we find, and so that we could provide those products, those devices to patients at no cost to them.
Right. Well, we are out of time. My other guests have been waiting patiently to come into the studio. But I wanted to let our audience know that the Arousalator, EROSCILLATOR is how you spell it, so you can look it up. And they have a 30-day money back warranty, and it costs $469.95. So that's really great that there's the money back part, and there are these different components you can add to it, which can make it more expensive than $469. So it'd be good when your insurance company can pay for this. But let's have you on.
We're working on that. We're working on it.
Yeah, but thank you both so much for joining us, and thanks so much for the website. For more information, and that's really great that there's a place for people to be able to go to get connected to the community around sexual and vaginal and urinary tract health. That's really excellent. And thank you so much for doing the work.
And thank you for having us.
Yeah, thank you very much.
You're quite welcome. You take good care.
You too.
All right, peace and blessings.
Bye-bye.